ascending infection of the kidney. Innumerable experiments have repeatedly proven that bacteria do not ascend from the bladder to the kidney in animals unless there is some accessory cause of infection. This accessory cause, both in experiments and in the human being, is usually some form of retention of urine. The routes by which infection may conceivably reach the kidney from the bladder are three. 1, up the lumen of the ureter. 2, through the lymphatics extending along the ureter from the bladder to the kidney pelvis. 3, by lymphatic absorption from the bladder or prostate into the general circulation, and thence by what is actually a descending infection into the kidney parenchyma. Evidence has been accumulating for years to disprove the theory that infection can travel along the inside of the ureter from bladder to kidney. This evidence has been summed up and made final in the observations of Sweet and Stewart. They have reviewed the evidence of the existence of a network of lymph vessels in the mucosa and submucosa, as well as in the external coats of the bladder and ureters and in the pelvis of the kidney, and have shown that this network anastomoses freely throughout. In their experiments, they have traced infection up these lymphatics and have shown, by replacing a section of the ureter with a tube that maintains the lumen of the canal but interrupts the lymphatic flow, that under appropriate circumstances, bacteria will travel up to the opposite kidney whose lymphatics are intact, but not up to the kidney whose ureter has been divided. Although the trauma of ureteral division should, in itself, lower the resistance of that ureter. How frequently such lymphatic infections of the kidney occur remains an open question. The familiar acute so-called ascending infections, such as is seen in postoperative infection, in prostatic retention infections, in urethral chill, and in defloration pyelitis, has been shown in several instances to be associated with the general bacteremia, while post-mortem examination fails to show any evidence of ascending lymphatic infection along the ureter. Crabtree cites a case in point. The patient entered the hospital for the treatment of a prostatic retention of urine. A catheter was tied in the urethra, and repeated cultures made from the urine obtained through this catheter failed to show any bacterial growth. On the 7th day, the patient complained of some uneasiness in the perineum. A blood culture was promptly made, revealing colon bacillemia. Meanwhile, the urine still remained sterile. Then the patient had a chill, fever, pain in the loin, and a sharp fall in the output of phenylsulfonaphthalene. Blood culture was now negative, but culture of the urine showed Bacillus coli. In due course, the phenylsulfonaphthalene output returned to normal. The patient submitted to perineal prostatectomy, and 2 weeks thereafter died of Streptococcus septicemia. Post-mortem examination revealed no gross evidence of renal infection or of lymphatic infection about the kidney pelvis and ureter. Such cases force us to the conclusion that the acute phenomena of kidney infection under the clinical circumstances enumerated above, although they have always been spoken of as ascending infections, are actually descending infections from a source in the lower urinary organs, or in the vagina in the case of defloration pyelitis. Thus, the absence of any positive evidence of spontaneous infection of the normal bladder from the normal urethra, or of the kidney from the bladder, leaves the theory of spontaneous ascending infection, quote, from the short urethra, end quote, of women without support. If this does occur, we have no theory whereby it can be explained.